Okay, so we're having a look here at chapter 41 of IGGI, and we're going to review the sympathetic and parasympathetic nervous system in 10 seconds or less. Parasympathetic nervous system is activated by acetylcholine, and that is your peaceful system. That's where your eyes constrict, your heart slows down, you need less oxygen, you're relaxed. Sympathetic nervous system is the stressful system, the fight or flight system. And that's when we have dilated pupils that we're dilating up to see the mass murderer chasing after us. It's making our heart race, our lungs need more oxygen because we're running. This is triggered by dopamine in the brain, and that's our two nervous systems, 10 seconds or less. When we are doing a neuro assessment, there's some key components. We're going to be looking at family history, genetic risks. Are there any neurological diseases that are prevalent in the family history? Any current health problems? The level of consciousness of our patient. Are they oriented to person, place, and time and thing? And so oriented times 4. And we're also going to ask them enough questions to assess both their short and long-term memory. We're going to listen to them, assess their cognition. Can they follow in 3, 4, 5-step commands? A cranial nerve assessment, their sensory function, and this is where we go from side to side when we're assessing sensory function. Are they able to discriminate pain? We start distally. If they can discriminate distally, they're intact proximal. So we go from side to side. This is often done by the dull needle prick sensation, palms, plantar. Motor function, remember that the Babinski reflex, although normal in infants, is abnormal in adults, so we're looking for that. And also their cerebellar function. So let's review some of the common neurological testing that we're going to send our patients for. To begin with, the cerebral angiogram, that's where we're going to have dye shot into the vasculature of the brain, and it identifies any AV malformations, narrowing of vessels, aneurysms, baryaneurysms come to mind quickly. So to get our patient ready for that, we need to make sure they have a written consent. We're going to assess for allergies. Always ask about seafood allergies and iodine allergies. We're going to keep them well hydrated because dye is flushed out through the kidneys. Checking their peripheral pulses because this is a vessel is cannulated and the dye is injected, so they will go in through likely the femoral artery. Skin prep to be done. We're going to explain also to them when the dye is rushed in, if it's injected in, or it's usually the injector that does it. There's a very warm sensation, and sometimes they feel like they've peed their pants, and that's normal, and they did not pee their pants. So also anyone, especially renal patients, we're going to check a BUN creatinine, but we want to see what their renal function is because this dye does excrete through the kidneys. Post-procedure, we're going to be doing neurological and vascular assessments until they're stable, keep them flat, check the puncture site, check pulses, fluids to flush the dye, make sure they have IV fluids on board. They're going to have to remain in a reclined position until we have hemostasis, and they may have some kind of closure device, and we would follow whatever protocol that comes along with that. So it's a fairly invasive type of procedure. CT scan, we're looking for hemorrhages, infarctions, abscesses, tumors, and we're just talking about the head right now. Also an informed consent. They can do a dye, so whether or not they have allergies, we need to assess for that. Once again, the BUN and creatinine. And if they are getting the dye, the sensation of warmth, and then the flush to the groin area. Post-procedure, no real instructions to follow. We're checking for reactions and then encourage them to drink fluids to flush that dye out. An EEG, which is an electroencephalogram, this is where you've seen pictures of all the millions of wires hooked up to the head. And the paste that they secure these wires onto the head with is like toothpaste, and it turns into cement. So when your patient comes back from these procedures, if they have an EEG, try and get that stuff out of their hair as much as possible. So they'll be in a quiet room. It's painless. We have to hold any stimulants or tranquilizers 28 to 48 hours in advance. So it's important for us to know what drugs they're on. No caffeine, cola, tea, cigarettes, Monster juice, Red Bull, all those weird drinks that you guys survive on. No caffeine for 24 hours. Sometimes they may use sleep deprivation for individuals. Pardon me, I have sleep deprivation. Anyways, they may use that, especially for children. And then they may ask them to hyperventilate because they have an increased chance to seize if they're hyperventilated. So that might be a command that might be given by the tech, and they may use strobe lights or bright lights to induce seizure activity. Post-procedure, like I said, get the paste out of the hair, give any meds that were held, and then watch for further seizure activity. Two bedside assessments that we often do on patients are the Glasgow Coma Scale, which has been around a long, long time, by assessing your patient's eye-opening, motor response, and verbal response. Best score is 15, worst score is 3. Typical neuro patients, they'll respond to sound by opening their eyes. They may obey commands, and what if they're mumbling or they're confused, you would give them whatever score they'd get. So the other one is when you visually look at your patient and see if they're posturing. A decerebrate is the top figure, which is B, and decorticate is the bottom. I always remember that by A. They're pulling to the core. Their hands come to their core. So decorticate is on the bottom and decerebrate is on the top. Okay, lumbar punctures in adults. We know we have them in children. We also have them in adults. This is an insertion of a spinal needle into between the L4 and L5, bony prominence of the spine, and of course it's done by a physician, and then cerebrospinal fluid is retrieved for testing. So if you look at the results down here, the first one is a clear sample, which is a normal sample. The second one would be show a previous meningeal hemorrhage, that dark color. The pink one on the end well, actually, I think the one on the end is more yellow. So the pink one, second from the right, is shows some RBCs present, and then the yellow one, the yellow one shows that there's bilirubin present related to jaundice. Also could be from a subarachnoid hemorrhage, and could be increased in the CSF protein. However, you're not going to have to make that call ever, but that's what they look like. So if you're assisting and it does not look clear, there's something wrong. So pre-procedure, you need to get informed consent from your patient. It can be done right at the bedside. Make sure the patient's positioned in the fetal position, They may be pre-medicated or may not. Standard precautions are definitely needed. You want to assess their skin if there's any rash or infection going on. You don't want anything. You can't do the procedure because they're at risk for infection then. So post-procedure, you're going to label the specimen, place it in a biohazard bag, do neuro assessments every 15 till stable, keep them flat. If there is a leak, they may need to have a blood patch, very similar to what's done, well, exactly the same thing is done to post-spinal patients, primarily in maternity. Moving onwards, here we have MRI. MRI is a huge magnet. So we want to make sure that there is no metal on the patients. Metal being implants such as pacemakers, insulin pumps, what other kinds of things? ICDs, AICDs, some tattoos, makeup tattoos have metal, a bit of metal in them, and that what ends up is that heats up the skin when they go into the MRI and burns. So you're going to assess for those things. Remove any metal on the patient and on yourself, because if you walk in there into the magnet, all that, your pens in your pocket will get pulled out into the magnet. And then they can go home and just resume their life. There's no post-procedural care on an MRI. Either is there for a PET scan or a SPECT scan, positron emission topography. And these are 3D images that assess physiological function of the brain. We're going to see strokes, tumors. They can diagnose epilepsy, Parkinson's, head injuries. This image below is nice, how you can see the MRI, the PET, and then the SPECT. So depending on what they're looking for, one is better than the other. So with the SPECT and the PET scan, there's an injection or an inhalation of glucose-based isotope, and that shows up. So once again, we don't want stimulants on our patients at least 12 hours prior to the test. Let's talk about the different cranial nerve disorders that are around. Trigeminal neuralgia, Bell's palsy, and acoustic neuroma. Trigeminal neuralgia, they will talk of a burning face pain, that excruciating, it's unpredictable, it's paroxysmal, there's twitching and grimacing of facial muscles. Bell's palsy is definitely on one side. You'll see eye closed, decrease in their corneal reflex, there may be more tearing, distortion on that side of the face, and then acoustic neuroma. There may be deafness, partial or initially, twitching, grimacing, and of facial muscles, and they're dizzy. So you can read through all these. Basically, it is to treat the symptoms, provide comfort measures. Occasionally there will be surgical intervention, and follow up in your textbook on these 3 conditions.